Dear friends, I am really elated and obliged to Physician Forum of India, Dr. Chauhan et al. To make me once more back-to-back moderator in the CME. It's my pious and delicious, I'm saying delicious, it's my pleasant duty to introduce a budding doctor, Dr. Shalini Goswami. And I enjoyed talking to her, knew about her talent. She's from, she's an alumni from Aligarh Muslim University, MBBS, and MS from the same place. And she's now working with Dr. Aloy Mukherjee. Dr. Aloy Mukherjee is, of course, he will be introduced more in detail by Dr. Chauhan and Dr. Hodar. He has been compared with Dr. Joy Mukherjee. The song, I am reminded, my song was from Hamshaya. Dil ki awaaz bhi sun, mere fasane pe na jaye. So I will not bore you with my tone of. So Dr. Shalini, Shalini se kehte hain, Shalini. So she is so nice to present her, she will present her medical part of Gastro Esophageal Reflux.
Both medical and surgery.
Of course, she will be first rolling the ball when the esophageal sphincter meeting the stomach is loose. It causes some symptoms. We all know it may be simple, it may be complicated, and when it is complicated, we need experts. For simple, everybody knows PPIs and all that, lifestyle management. For complicated ones, when we have no response to medicines, anemia, over 50, dysphagia, odynophagia, whatever. So all these need the help of experts. I now invite the experts. Please come.
Let's greet them with a big hand.
Good evening everyone, myself Dr. Shalini Goswami, and I'll be discussing gastroesophageal reflux disease, or more commonly heard as GERD, and even more commonly heard as acidity in our common households. In a room full of people, we'll get so many cases which will complain I have acidity. Even in this room full of doctors, right now we will get so many people who say I have acidity. So this is the disease with the concern. I'll be discussing about the introduction, symptomatology and after treatment. The first question is why GERD? Why do you need to discuss it? The quality of life surveys reveal that the GERD patients, their lives are impaired equally or even more than the comorbidities like hypertension and diabetes. And the bodily pains are more than that of major depression. So this is something which is very under-evaluated and needs the attention. As per definition, it is a condition which develops when the reflux of stomach contents causes troublesome symptoms or complications. This is the standard definition given by Mukherjee et al., which is a group of 44 experts working exclusively on GERD. The symptoms vary from heartburn till globus, and this is taken from Cmes textbook of surgery. The prevalence of heartburn is maximum in like 80% of the cases, followed by regurgitation, pain, cough, dysphagia, and the list goes on. The extraesophageal symptoms can also be the main presenting complaint. In laryngeal symptoms, they can be hoarseness, throat clearing, throat pain, globus, choking, up to contact ulcers, and in pulmonary symptoms, even chronic bronchitis and idiopathic pulmonary fibrosis can be the presentation. The progression of GERD ranges from NERD to BE. NERD is non-esophagitis reflux disease, then mild esophagitis reflux disease, severe esophagitis reflux disease, and ultimately the Barrett's esophagus, which is pre-malignant condition. Based on these all symptomatology and presentation, the complications of GERD vary from mucosal, extraesophageal and metaplastic. Now, as I have given the brief idea about the symptomatology, how do we proceed? What is the workup? The main investigation are these four: pH testing, esophageal manometry, esophagogram and upper GI endoscopy. We all have heard about these. The pH testing, the ambulatory 24-hour pH monitoring is the gold standard for diagnosis, and it gives us a score, D-Meester score. If it is more than 14.72, it confirms the diagnosis of GERD. Second is manometry. Now I'll take a little bit of your time to elaborate this high resolution manometry. Although it is not the one which will diagnose GERD, but still I am taking down time because this is the one which will rule out that when it is not GERD and when the path of our treatment differs. Based on this high resolution manometry, we get two parameters. It looks very dangerous, but it is IRP and DCI. Based on the manometry findings, this is integrated relaxation pressure and distal contractile impedance. Why I am telling about these two boring people is that on the basis of this, we get this classification, the Chicago classification of esophageal motility version 3.0. This only single table can tell you anything about the motility disorder, and it is based on only these two, IRP and DCI. So anything whatever the value of these two, you can classify in this table, and you have your diagnosis in just by this one single table. So what is the need of this? I'll tell you a few examples. Like if a patient with mildly impaired motility, according to this table that I just discussed, and a positive pH testing also. So we will do a floppy quantification in this and not a full wrap. Another example is a patient with a long-standing GERD will have esophageal dysmotility. They must be counseled for a post-operative dysphagia after the fundification. And lastly, if there is severe motility disorder, we are going to advise them treatment other than the surgery. Then we have endoscopy. In endoscopy, we will look for the signs, the indirect signs of GERD and not the GERD per se, like esophagitis, metaplesia, and we rule out masses or strictures and hiatus hernia, which is the main cause of causing gastroesophageal reflux. This is the slide showing the endoscopic view, and it's called Hill's grading. It classifies the gastroesophageal junction into the four. So in the first, we can see there is a prominent ridge. There is a prominent ridge in the gastroesophageal junction. This ridge is not as prominent as the first one. Here it is barely visible, and in the last there obvious hiatus hernia is seen. So on this basis, this grading is done on endoscopy. And lastly, a very conventional investigation we have since all time, esophagogram. Direct evidence of some diseases are seen in this. In the first picture, you can see there is a bird wheel appearance. This is for achalasia cardia. Here you can see a sliding hernia into the chest. This is paraesophageal hernia. And now, after all this, let's come to the treatment part. Always we start with the medical management. We try to avoid surgery as much as possible, although I should not say it, I am a surgeon. But still, I'll tell you a brief about the medical management. In pharmacotherapy, PPI is still the drug of choice. All people are taking it over the counter also, but this is only the medical management of choice. A 8-week trial period is given. It is taken from the Mango's abdominal surgery, the latest edition. But what is the flaw in this? The 66 to 75% of the patients with NERD and almost 100% of the patients with erosive esophagitis when they stop the PPI for almost 6 months, there is a relapse. So maintenance of PPI is given for lifetime. So in lifestyle modification, we can do cessation of tobacco and alcohol. I should not be saying this right now. Weight loss and elevating the head of the bed. There are few non-pharmacological treatments which are like bridging therapeutic gap. Examples are radiofrequency ablation therapy, transoral incisionless fundoplication, and magnetic sphincter augmentation device. These have come up in last decade, although there is no promising result which is seen. There is a lot of recurrences and relapses, so ultimately the management of choice is surgical management only. But it is a saying which says that a surgeon should know when to operate and must know when not to operate. So when not to operate, I have told you according to that Chicago classification. And now coming on when to operate, we have indications when we should know that now you have done enough with the PPI therapy and every lifestyle modification. Now come to my OR. The indications are symptoms that are responsive but not completely eliminated by the PPIs. Heartburn has been eliminated, but still there is reflux. The reflux symptoms, the complicated ones we discussed, chest pain, cough, wheezing, and the pulmonary complications. The GERD complications like stricture or premalignant Barrett's, which while still patient is on PPI twice a day, but still these symptoms persist or progress. And lastly, in a patient with a well-documented GERD who desires to stop the chronic PPI, like you have taken PPI for 10 years now, obviously you don't want to continue it for life. So these are the indications for surgery. What is the aim of this fundoplication surgery or any anti-reflux procedure is, we mobilize the lower part of the esophagus to create an intra-abdominal length at least 5 cm of the esophagus. And when the hiatus is also enlarged, we suture it. We do pleuroplasty and prevent the wrap from being pulled into the chest. And wrap the fundus of the stomach either partially or totally around this intra-abdominal esophagus. So standard surgery, gold standard surgery is laparoscopic nasal fundoplication, heard by all. And regarding this surgery, there is this paper written by Dr. Aloy Mukherjee on laparoscopic nasal fundoplication, from which I have taken all the images also. They have introduced how the ports are made in the particular surgery. This is the esophagus mobilized. This is scleroplasty which is done. Still we leave a little bit of hiatus so that there is no post-operative dysphagia. This is how fundus is wrapped, taken posterior to the esophagus mobilized part and anteriorly it is wrapped. So this is a brief description of how nasal fundoplication is done. Lastly, there is one common clinical scenario we see in our day-to-day life. A patient with difficulty in swallowing, heartburn, chest discomfort and everything. Giving a history of dysphagia, regurgitation for past 6 months and dysphagia developed for last 3 months, heartburn worse at night, not responding to antacids, and nothing much but mild anxiety in the medical history. And in diagnostic workup, we see this kind of picture in esophagogram. This is called corpuscular appearance. It is suggestive of some esophageal motility disorder or spasm. Secondly, we do manometry, and according to the table, if you remember, if the normal median IRP and DCI is more than 450, more than 20% of the premature contraction, it defines diffuse esophageal spasm, which was categorized under the major disorders of motility. Then we do endoscopy, which shows signs of esophagitis, and in 24-hour pH monitoring, the DMEST score was 35.28. So from all this, we have a positive pH testing, which diagnosed GERD, and we have a positive motility disorder also. So we have the diagnosis of GERD with diffuse esophageal spasm. So we will obviously manage the patient conservatively and not by the surgical management. There is this brief video, if you all will allow, I will show you. This is a laparoscopic nasal fundoplication done by Dr. Mukherjee. We retract the liver so that we can see the hiatus. height is here. This is the greater curvature of the stomach, which is released so that we can allow the mobilization of the fundus later. We try to preserve the gastroepiploid arcade around the greater curvature. Just went off. So the arcade is divided till the hiatus, then we take the wrap posteriorly, and one thing we should remember is that it should be an esophageal wrap and not an gastric wrap, otherwise the patient will develop the postoperative dysphagia. The take-home message is GERD is a condition which develops when the reflux of stomach contents causes troublesome symptoms or any kind of complication. And by understanding and managing the GERD, patients can significantly improve the quality of life, which is ultimately the aim of any management and risk of complications. Thank you for your patient hearing.
Thank you, Dr. Shalini. Now, Dr. Podar to take over.
Thank you, Dr. Shalini. I think your video, you must, the wrap which she was telling, it should not be very tight, otherwise it will be dysphagia. If it is loose, there is no point of surgery, there will be recurrence. So this is very, only experienced surgeons to do this surgery, those who are doing regularly. All surgeons are doing laparoscopy, gallbladder, appendix, but fundoplication should be done by those who are doing regularly. So thank you. We will take question answer at the end of both the lectures. So next speaker, it's my privilege to introduce Dr. Aloy Mukherjee. I know him for last 15 years. He is a senior laparoscopic, bariatric and robotic surgeon in Indraprasth Apollo Hospital. Has 24 years of experience after doing MS, and he was trained in All India Institute of Medical Sciences. He is also a member of National Academy of Medical Sciences. He has done fellowship in bariatric surgery and robotic surgery. He is a member of almost all the surgical associations, including our own ASI, MIC, and the IAGS, Obesity Surgery Society of India. And he has presented many papers in journals also of repute, both national and international. One paper she was showing on reflux disease also. So I request Dr. Aloy to start the talk. First talk will be on what is new in laparoscopic or robotic surgery, and then something like medical management of obesity. So both the lectures you will take in continuity, and then we will have question and answer. Dr. Aloy.
Good evening, gentlemen. Good evening. It's my pleasure to be a part of this amazing organization. This is my maiden presence, basically. In fact, I didn't have this opportunity before, so I'm really happy to be here today. So, and meet so many distinguished physicians across Delhi. In fact, it is my honor. The talks will be there, and we look forward to being here again soon. So, since it's an August gathering, it's late in the evening, we'll just talk about what we do in minimal access surgery, and what has been the newer trends in minimal access surgery over the last decade or over the last few years. So I thank Medtronic India for organizing this, and really I thank you for organizing this and getting this in place. We will definitely get you over for a couple of slides once our talks are over. Thank you, Adil, for this. So, minimal access surgery conventionally, as everyone of us knows, is surgery through tiny incisions, laparoscopic, endoscopic, robotic. Any means can achieve this, and any part of the human body, be it in the head and neck, thorax, the abdomen, or even in vascular surgery. So this can be achieved in any branch, be it neurosurgery or a cardiac surgery. So we all know that it causes faster recovery. Now this is a chart which is very important to see because this is a South American paper I came across while making this. Now it has traditionally compared the 3 types of procedures with observation. So as we can see this list from the incision size to the cost to the complication. So every, the minimal access have scored more over the traditional procedures with fewer complication in experienced hands. Obviously there's a steep learning curve, but again, any procedure of, any procedure which has good outcomes would definitely have a good learning curve. So these are the equipment. So we all remember surgeons are also there in this forum. As Dr. Poddar would also agree that we started with probably single chip cameras in the 1990s, and now we have 4K and 8K vision. Even the quality of laparoscopes, the hand instruments, they've all evolved over the last few years. Now this is the Da Vinci XI. Now we have, one of my friends in the US. He has bought this latest version, the DV5, which is the latest version of the Da Vinci. So, and there are many other robots in the forum. So basically, it has all evolved over a period of time to achieve fineness, to achieve this fine sense of dissection, so that the patient goes home early. We have a cleaner dissection. The target organ is approached in a better way, and we don't spill over many things during this process. This is again in a schematic diagram showing. Now, so there are advanced intellect systems in place. Now, whenever we speak of newer instruments, newer things like robotic surgery, how it helps. So, as you see, from the haptics to the wearables to the visual imaging, actuations, position, all of these are integrated into this and at different levels. So what it helps the surgeon at different levels, from the console surgeon to the surgeon at the table, to the depth of the image, to the biofeedback. So many things are involved whenever you want a good surgery or a surgery with a good completion, with minimal blood loss and a good clearance. So a surgeon always strives towards excellence. So if a surgeon is striving towards excellence, he always looks forward to a perfect algorithm so that things are in place. So this is achieved by newer achievements or the newer robots, especially if you look at them, the Da Vinci or the Hugoras by Medtronic, all of them have achieved this. This is a slide which shows, now look at this, vaginal hysterectomy done in 50 BC. I was looking at the slide, and the first robotic surgery, Dr. Tormaso performed it using a Zeoff system. So this is a journey from 50 BC to 1994. So, and this shows the conventional minimal access procedures along with the timelines. So the development has been mostly in the early 20th century and the early 1990s, where the first laparoscopy was performed in 91 perhaps. And nowadays we have all the equipments. Now it has gradually spread towards multiple disciplines like neurosurgery, pediatric, urology, orthopedics, vascular surgery. With the integration of robotics, we have greater precision. Now, I don't know how many of us have seen a robot being in place. So if you look at that instrument, even if you are practicing, it has got extreme high degree of precision, even up to the last millimeter. So when we are operating, we have got tactile feedbacks, it has got algorithms in place. It will stop you from doing many things. So, in other words, what I mean to say is, if you are in the right path in your training and you have the right instruments only will not help you. Then there is a long way to go in surgical training these days. And with this, along with image and navigation, the 3D image, the 3D reconstruction and the computer-aided navigation systems, things have been really easy. Training has been a problem, and in this there are different fellowship courses, ASI and IAGS. Many of the domestic forums have come up with newer training modules. They are giving fellowships in minimal access. IAGS has so many training courses in robotics, in different specialties of minimal access surgery. Medtronic also does a base program wherein we train surgeons for hernia surgery using minimal access methods. So obviously this is just showing you the resistance from the surgical community in the early 1990s to the present era of AI and AR. Now, artificial intelligence and augmented reality with nanotechnology, personalized surgical approach. Now, future directions are something that we should all look at. Now, nanobots are in place wherein they can go to a particular organ. They have particular, nanobots which can be injected into the system. They are self-destructing, and they would, especially in oncosurgery, they would do the dissection, they would kill the target tumor cells, and they would self-destruct. Similarly, personalized surgical approaches have also come up, wherein you have 3D printing. Suppose you imagine a road traffic accident where half of your jaw is broken. So there is no titanium implant which is fixed to that. So you have personalized surgical approaches where you can do 3D printing, where you achieve that, and then you can actually have that in place. So all these have greater patient outcomes. Along with ERAS, now we'll talk about enhanced recovery after patient recovery after surgery. Now this is something again which has brought minimal access surgery to the forefront these days. Now with patients, we have early ambulation, less amount of opioid use, and also there are certain sets of protocols which are in place which ensures that the patient goes home very early. This is done for almost all patients undergoing bariatric surgery or any procedure which in open surgery would take a longer time. Now, all this enabled us to take a global traction and adopt a uniform adoption for this. And there are different workshops and collabs which has helped it evolve. So all this has enabled minimal access surgery to evolve over the decade. The economic impact, obviously, the robotic surgery definitely still now today it has very high costs. At a pull, I would say it costs about 1.5 to 1.2 to 2 lakhs per surgery extra. But definitely it gives you that added advantage. And along with advances in analgesia and anesthesia, definitely minimal access surgery has grown. So these are the advantages and the advancements and how it has impacted. So I will just quickly run through this. So these technical innovations have enabled us to achieve greater precision in the type of surgeries like I just mentioned, and the specialized procedures like bariatric thoracic procedures, they are done with greater dexterity. Now patient-centered outcomes have been collated, and it has shown that enhanced recovery after surgery programs, they offer minimal hospital stays, they have reduced this, and along with good traction, good amount of training, so this is going to be the mainstay. And let me tell you, future of minimal access will be robotic. 10 years down, 15 years down the line, there will be laparoscopy would also be gone. You would see only robotics. You would see AI and virtual reality, augmented reality being used everywhere. So this is the future of minimal access. So I was just speaking about this. So it shows the bile duct. When you see the hepatobiliary anatomy very clearly seen here. Same thing when you're doing an anastomosis, especially colorectal surgery, left-sided colonic anastomosis. So left-sided colons have less blood supply compared to the right side. So the chance of leakage are more. You use indocyanine green after the anastomosis. So this has really helped us to see the vascularity post-operatively. Now, so also I would say enteroscopy. Now, enteroscopy, especially if you are doing, suppose you're doing a small bowel stromal tumor and you want to see what is the extent of resection, or if you want to see if there are any smaller cysts left behind. So intraoperative enteroscopy can be used during the procedure. So these are the robotic GI surgery procedures. And this is the gamut of the procedures, starting from colorectals to esophageal procedures to pelvic procedures. All of these can be done. Next is bariatric surgery, everything. So if you can see the topper up, the image up here is the robotic instrument. The image lower down is the laparoscopic instrument. If you can see, this instrument has 360 degrees of freedom. So you can negotiate corners very easily. The other emerging minimal access techniques in minimal access are endoluminal procedures like endoscopic sleeve hysterectomies, endoballoons, the Aloy pill. And there is an AI and machine learning which stratifies the risk, the intraoperative management, all of the clinical management, all of these can be actually tackled by this algorithm which can be used through AI. These are the staplers which the robotic and the laparoscopic staplers are. Just come to this. So this is a smart fire which robotic uses from Intuitive, and this is the AI generated stapler from Medtronic which gauges the tissue thickness precisely. So if we now once we are resecting, it will just go and stop there if the tissue thickness is more. It will tell you that we use an alternative cartridge because this cartridge is too thick. This would not help resect this. So we have to change the cartridge. So all these algorithms are in place, AI generated. Endocrine minimal access surgery. Now, this was a chapter on thoracoscopic thymectomy which I published. So this is, I'll just briefly go through this. So this was a small thymoma. Patient had myasthenia gravis. What I want to say, like when we used to do when we were at All India Institute, we used to do this open. So the patient was, stuck with a chest tube for almost 7 days in the hospital. Now with this, once we do this, the patient is out of the hospital in a couple of days with resolution of the myasthenic symptoms. If they have, if the proper workup has been done. So all the dissections are carried out very neatly, and the visualization, if you see the lung, the inferior vena cava, the phrenic nerve, all of these can be very clearly delineated. If I can actually go through the anyway, let me just jump through the video. So recent innovations in minimal access thoracic surgery has been uniportal thoracic surgery. I don't practice uniportal, we do multiportal, but this can be done. And I would come to adrenals next. Now, so if you see this left adrenal, I was just mentioning everybody that we do a lot of adrenals. If you can see this left adrenal mass, this is almost an 8 centimeter left adrenal mass. Both are my slides. This is a smaller one. So this was a pheochromocytoma, 7.5 centimeter pheochromocytoma, very neatly dissected using laparoscopic means. This was probably a pons which we did maybe a couple of months back. So one was robotic, one was laparoscopic. Anyway. Same can be done. Like I was mentioning, parathyroids can also be done. This was a very large parathyroid, almost you can see the weight of the parathyroid, 15.5 gram parathyroid, and with a 2 centimeter incision here. So we can, with a smaller incision, we use minimal surgical techniques to dissect out and clip the thyroid arteries, the parathyroid vessels. Identifying the recurrent laryngeal nerves, so everything is in the planes are maintained. and the patient can go home the next day. If the endocrine people can actually relieve them. Hypoglycemia is a very common feature post-parathyroidectomy. Similarly, we have this transoral thyroid approaches. We have the RATS, remote access thyroid surgery. So all of these can be done without any incision in the neck. So this is remote. Now abdominal wall reconstruction. Now we have conventionally thought of these as hernias. Now these are not hernias. Here most of the muscles are missing in the abdominal wall or they have receded to far corners in the abdominal wall. So how do you reconstruct these things? So these require meticulous planning in the form of a contrast CT. And then once you've seen the CT, you have to ensure whether the patient is directly fit for surgery or whether the patient requires a botulinum toxin or any other method to get in the muscles in close proximity here. So we use things like pneumoperitoneal, progressive pneumoperitoneum or the Botox to ensure that these patients actually have shrinkage of the defect. Subsequent to that, we either plan these procedures, which is nowadays called AWR or abdominal wall reconstruction, using different component separation techniques. Now most of these can be done robotically, laparoscopically or by open methods. But what I was trying to say is robotic and laparoscopy has ensured that the planes can be maintained even better and even the smaller vessels are magnified. So actually suppose you are doing a component separation, everything are very detailed seen there. So we do not injure, the chance of injury are less, the dissection is more meticulous and obviously you have the benefits of a minimal access surgery there. So hernia has evolved from a conventional TAPP, TEP to the different forms of component separation we have now. Again, the different meshes from the conventional polypropylene which was available in the 1970s, 80s and 90s. Now we have so many different types of mesh, including bioresorbable mesh, and along with that we have the barbed sutures as well. Now these barbed sutures are ensured that when you are bite, you don't have to knot it, it stays in place. So all these are advancements which have gone in favor of minimal access procedures, including the mesenchymal stem cell implant for meshes. So these are robotic mentor platforms, again for robotic surgery. So these will mentor people or students who are, you can undergo simulation training very well here, and it will tell you how you score, whether you are ready for your porcine model. And they have the different AI and all the algorithms which I am going to tell you. Look at this slide. So all of these good cars nowadays, they have this ADAS system. So ADAS is something like, we have this advanced driver assist system. So what I named it is advanced surgical assist system. So all our new surgical equipments have come with this advanced surgical assist system. It helps you decide and stop. Be it a robotic, be it the newer laparoscopic instrument, you can actually have this algorithm to actually stop your procedure, or you can pause when you are hitting a vessel. Especially because most of the groin hernias, we have large structures like mostly the external iliac vessels, those are very commonly injured. So it is important that during training you have something which puts a check on you. So I would just come to AI and machine learning. So these have helped in, better outcomes. And if you will see this video, now they are doing a distal gastrectomy, and this artificial intellect based instrument identification system. Now, once they build this dissection, if you are going too close to the tumor, it will light up like that. So you need to have a certain margin away. Only then. So I'll just quickly, sorry, we're running late. So basically, Now I'll come to telesurgeon, remote robotics. Again, the different systems which are in place today. And patient safety, minimizing complication, the ERAS protocol. The manual access surgery, definitely. Steep learning curve, cost and accessibility. This is a game changer. Nanotechnology, 3D printing, as I mentioned, AI and robotics are for the future. I think let us close this now. Thanks for your time. I will just invite Deepa for medical management of obesity. Just briefly she'll finish. It will not take much of your evening time.
She will take just 5 minutes.
5 minutes, not more than that. I can see people going out. So
We can discuss.
I think we have.
We can discuss this.
Yeah.
5 minutes.
Are we done?
Finish in 2 minutes.
Finish in 2 minutes.
Okay. Now I'm going to discuss about the pharmacotherapy in obesity. Do you think obesity is not a rocket science? How many of you are agree with me? It is more complex than that. And now, what are the approaches which we can do to address obesity? I'm not going in detail, just I'm going to tell you about the pharmacotherapy. And pharmacotherapy is the tool that helps in obesity management. There are, we all know about the algorithm, how we can divide the patient as per the BMI criteria. I'm not going to address all these things. Just I'm going to tell about the current. This pharmacotherapy works on the basis of the neural signals and satiety, controlling the satiety and giving you the feeling of the fullness. There are few FDA-approved drugs that will give us anti-obesity drugs are available in India. That is already said that with this medicine, it's just a lipase inhibitor, and nowadays the most common talk of the town is semaglutide. And we were using the liraglutide as well. We are getting the good results with the liraglutide, but now the oral semaglutide is going to give us a more benefit. Mechanism of action, as all you know about this, that's why I'm not going to tell you in detail about this. It's a meta-analysis conducted by the JAMA 2016. Here, they conducted trials and the result is like this. Here we can see that in the placebo group there is no weight loss, remarkable weight loss, but in the liraglutide group, 3 mg, we can find a very good weight loss. Now I am going to talk to you about the references, that is semaglutide. It is like that we have to initiate the pharmacotherapy at right time, and we have to just check the patient if the patient are getting the benefit with this medicine or not. If they are going to get the benefit, they will get benefit in initially 26 weeks only. If they are not going to get benefit, we have to once the degenerative changes will happen, we can't correct that. We can stop the progression of the disease. And patients like obesity, whenever the obesity is there, patients are having the issues like sleep apnea, diabetes, cardiovascular diseases. And judiciously we have to decide which obesity medication is going to help them. And nowadays, SGLT2 inhibitors are also are very common endocrinologists, and they are using for the weight loss as well as controlling the diabetes. But we have to check when we have to use the semaglutide and when we have to use the SGLT2 inhibitors. In the semaglutide, I had conducted the study personally, and I
I found that in the semaglutide group, patients are getting the more greater weight loss as compared to the other medication like liraglutide, dulaglutide. And in the semaglutide group, the patient got the good benefit of around even in 25% of the patient, I had seen the 37% of the weight loss. That was conducted by this study was conducted at my center, but I did it in the bariatric surgery group. Now we have to decide when we have to refer the patient to the bariatric surgeon, or till what time we can get the benefit of this pharmacotherapy. As I told you that we can get the initial, only during the initial 26 weeks only we can see the results. And this pharmacotherapy also, like this semaglutide, these drugs also causes some adverse effect. That's why patient can't tolerate, GI disturbance will be there. And there are withdrawals, patient can't take it for a longer period of time. At that particular period of time, we should refer the patient to the physician or surgeons. Now referral is it's like we are very careful about the patients. We don't want to give the patient to the any person, but we should give the we have to recognize the center of excellence where we can give we can refer the patient, and we have to identify when the patient is not at which point. They definitely very finite. At which point patients are not getting to get benefit, and we can refer them to the bariatric surgery. After bariatric surgery, also there is a role of the physicians, and we have to very we have to take a new. Okay,
Actually, our friends are saying there's always a next time.
Exactly. That's
I think just this anti-obesity medicines like reversals and bariatric surgery,
Yeah.
they are complementary to each other. They are not in competition. Many doctors ask us that bariatric surgery will be much less after the invent of drug like liraglutide or semaglutide. So both are required, the medicines and surgery. So it is complementary to each other. We will discuss obesity detail next. Dr. Chauhan has asked in March.
Yeah,
We
March
will be
26.
only in obesity, medical management, surgical management.
March 26
Thank you.
is decided, sir.
Thank you. You can join.
Dear friends, so we had a very nice talk. Of course, some of our friends have diffused. So let me set the ball rolling. Dr. Tulsi is very keen to ask some questions. Like you must have heard in Mahabharata there was some person known as Yaksh.
Yes.
He asked 100 questions. So Dr. Tulsi will ask you 10 questions. Each question will be equivalent to 10 questions. So it will be 100 questions. My just first question or first comment is, GERD is basically caused because of increased intra-abdominal pressure. It can be due to fat, platters, fetus, fast food, faulty habits like smoking or whatever. So that is one thing. And the management is just opposite of the stents. In the stents we want to keep the passage open, and here we want to close it. It's just opposite of that. So it can be done by whatever means. It can be laparoscopic or per oral, whatever. And my last question, which I am asking you, to imagine that there will be surgeries done without a surgeon, because we have cars being driven without drivers. That is a food for thought.
Yes, yes.
Food for-
I was, sir, thanks for your wonderful comments and queries.
Whenever artificial intelligence is used in robotics, he said many staplers are there, but there also natural intelligence is more important than artificial intelligence. Your natural intelligence will always be required. Yeah, Doctor Aloy.
Yeah, absolutely, sir. In fact, I was reading a small little snippet which came in one of the WhatsApp groups that was mentioning about a newspaper update in New York Times, in which probably ChatGPT, they scored people, residents, and they scored ChatGPT. And they found that AI scored much above surgical or medical residents. So in terms of diagnosis of a disease, so they were evaluated for diagnosis of disease, and I think ChatGPT was, I think, 90%. And above 90. Correct. So definitely we are heading in that direction, and but surgery is something, I would say, everything doesn't fall as an equation there. So there are many roadblocks or many things which come up which are not defined. So as we enter an uncharted terrain, definitely, and when you have an AI or a VR, you would see them, analyze them, and then take the action. But that would take, all those things would take some time because it's not pre-fed. But whenever a surgeon is operating, he uses his analytical skills and his experience. So that pre-fed thing is not there. It is actually whatever you are seeing on the field. So it will be difficult, I guess, to replace surgeons in the near future.
That's why I said natural intelligence of a surgeon is very important than artificial intelligence.
Correct. So as far as driverless robots or driverless operation theaters are concerned, I think we have to wait a while.
Our esteemed Dr. Amishwar.
So, the FDA has recently approved vonoprazan for GERD.
Correct.
Would like to know more about the same, because there are so many Me Too FDA approvals come every time.
Correct.
Then there are inflammatory GERD, non-inflammatory GERD,
Correct.
erosive GERD, non-erosive GERD. How does one take it forward?
Absolutely. Thank you. So, vonoprazan has recently come, and definitely they have claimed that the incidence of reflux has, they have reported a 24-hour remission, which is much more than the PPIs, and especially in refractory GERDs. So anyway, only time will tell how that, because every company is coming up with vonoprazan, every MR will come and talk about it in your clinic. So that is something that has
One additional advantage of vonoprazan is you don't have to depend on the timing of the
Correct.
PPI has to be taken 45 minutes before meal, but this, yes, that is.
Just Dr. Amish has asked a very important question, and we should answer it as best as we can. Dr. Amish, the vonoprazan is the potassium channel acid blocker. Okay, there are three types of channels in the stomach which are responsible for acid secretion. One is the active channels. Some of the channels are dormant channels, and these dormant channels are the ones which become active during the night, and they are responsible for acid breakthrough. So what it does is, the vonoprazan, as compared to PPIs, it blocks all the three channels.
Have you changed the practice?
So yes, I have changed my practice. There were a lot of people I was treating with a combination of BPI and domperidone or maybe lacerite, but those patients were still having symptoms at night, and because of the breakthrough acid secretion. So this after but please understand, you cannot give both. Do not give both. So give only vonoprazan, and the beautiful thing which Dr. Goswami also alluded to is, it is independent of meals. You can give them any time, and it is a game changer. It is a real game changer because it is blocking all the three channels, right? So that is the difference.
The only concern we have is of that of achlorhydria, because that and later on, carcinoma stomach incidence increases. So long-term effects need to be quantified.
Time only will tell, as lot of seniors, from the profession say new drugs are like new friends. First month, beautiful, wonderful. But as time goes by, you try and find out only faults. and no goods. So let's wait. Let's wait. Maybe after a year is the right time to talk. But it is a good substitution for people who are complaining of breakthrough symptoms, and many of them do. Many of them do. So it's a good molecule to have. It's a good something which is changing the game. I'm sure Dr. Kantu sir.
Just one question. Earlier in laparoscopy we started with single chip camera, then we had 3 chip camera, now we have 3D laparoscopy. So I have some experience of 3D laparoscopy. I think it's wonderful to see the CBD. You said ICG dye, but without that dye injection also we can see in 3D very clearly CBD. It's very difficult to endure as CBD on 3D. And in robotic, then we in open surgery era we had advantage of 3D view. Then in laparoscopy we lost that view 3D. Now in robotic and 3D laparoscopy we have regained that 3D. That's the advantage of robotic also. Anything you would like to add?
No, definitely it has been a game changer, especially when you are in a robotic console, you feel that you are on the field. Absolutely, there is nothing short of an experience which I can express here, because you are right in the middle. So any of you who have seen VR, virtual, what do we call that? Virtual reality, where you wear that eyewear.
Whenever you have to use 3D laparoscopy, you have to wear
No,
that.
not that. I was talking about virtual reality. So if you have the virtual reality experience, something similar to that, you are in the arena. You are right in the middle of something, except the haptic, the tactile feedback. Everything else is in place. That too is going to come in very soon. And 3D immersive laparoscopy, like I said. So we have a 3D system at our institute, and especially if we are doing, like I was saying, if you're doing a solid organ surgery or you are doing finer dissections, it definitely helps you, because the depth of the field can be negotiated. Otherwise, there is nothing, no amount of clarity. But for routine laparoscopic work, even the 4K or 8K systems which have come into place, they are always a game changer.
Striker system is
Striker system, 1688, 1688, it's a wonderful piece. The only problem is that everything has their own small little thing, but I know definitely they are coming forward in a big way.
Dr. Kantu sir. No, I'll give.
You have the mic.
Dr. Kantu sir will answer the question.
one question.
For this fundus application is helpful to improve the side symptoms of this.
So basically, make a patient very well.
And what are the complications?
So I'll just come to that.
Complications, how much does it cost?
So fundoplication basically we do for patients who are refractory to PPIs. So we give them a good PPI coverage. Now vonoprazan also, we'll try and vonoprazan also. So most of these patients, they would have megaloblastic anemia or ectohydria. So if they are on a PPI for a long time. And also the risk of, since reflux also increases the risk of Barrett's and Barrett's esophagitis and its sequelae. And you have different forms of esophagitis also. So from the LA to the LAT. So if you have large esophagitis, large ulcers coming, people who have Barrett's or any form of metaplasia on an endoscopy. So those are candidates who are selected for the procedure. And again, we do religiously, like she said, Shalini said, that we do the endoscopy, we do the manometry, and we do the 24-hour pH metry as a standard for all patients undergoing this procedure, because we want to rule out conditions like a diffuse esophageal spasm or conditions of a corkscrew esophagus or some form of achalasia types, the lower type, maybe a type 1 achalasia, wherein the patient may not be that symptomatic, but whenever you do the distal contractiles, so the pressures will reveal that the patient will have the disease. So in those cases we will not do the procedure. But in candidates in whom this procedure is selected, they do remarkably well, sir. I would say that within about 5 to 7 days of the procedure, within about a month, everybody is off PPIs, not even an H2 blocker. I don't prescribe anything beyond 7 days. 7 days I prescribe because of the pre-existing esophagitis which the patient must have carried because of that. So after that, we stop everything, gradually taper and stop. The patient is followed up religiously. We have almost about a 1.5 year follow-up so far, 2 years maybe. So they come, and most of them are doing well.
It is metaplegia
Is required, and that has to be sequentially followed even after the procedure. Because now we have bile reflux and acid reflux is gone, but again that has to be followed very clearly. Also,
I wanted to ask you a question regarding hiatus hernia.
sir,
Usually when we send our patients for and they are diagnosed as hiatus hernia, the first thing that is given is lifestyle changes
Correct.
and PPIs, and now of course vonoprazole. Sir, at what stage do you decide that this is a patient for surgery?
so like I said, if it's a very large hernia, number one, the structural defect. How big is the hernia? How big is the defect? So normally, if for a Hills 1 or 2, nothing. For a Hills 3, we are a little suspicious. If the patient has defect, a hiatus more than 4 centimeter with so many symptoms. So the size of the defect, the duration of symptoms, concomitant if they have esophagitis or any form of changes in the esophagus, and any lifestyle, or if the patient has been on lifestyle changes, or any other form of medication which the patient has been refractory to. Now, these are absolute indications where I would take the patient for it.
Sir, many times we see that hiatus hernia is associated with obesity.
Absolutely.
And you are a champion of bariatric surgery. Now, if I send my patient to you and you diagnose him obesity class 3 and hiatus hernia, you will do only bariatric surgery that is going to benefit his hiatus hernia, or you want to do both the surgery?
Excellent question, sir. I would. This is a very pertinent question. I missed that answering that in your last thing.
Which type of bariatric surgery?
So exactly, which type of bariatric surgery? He knows what I'm trying to answer. So I just published in the Oxford textbook, Oxford Journal of Surgery, Roux-en-Y gastric bypass is one-step solution for hiatus hernia and obesity. So it depends. So if you have a large hiatus, you have patients with reflux and like you mentioned, class 3 obesity. Absolutely just spot on. It's a RYGB, Roux-en-Y gastric bypass. You do RYGB, the patient's hiatus symptoms will disappear. Number one is the small pouch, and number two, you're rerouting it way down into the jejunum. So all the symptoms will disappear. So that would be the ideal choice. Still, if you see that the patient doesn't want a bariatric, sometimes not all patients can get counseled. They would have their own apprehensions and fear. So in that case, simply doing a nasal fundoplication would again not help. So those are a subset of patients who need to be counseled and who need to be, they come under the cusp. So they are neither in the surgical fora and neither they are getting responded by medical therapy. So if other forms, maybe they don't want a bypass. Sometimes they are young patients, sometimes young females, sometimes young males. They don't want a bypass because bypass causes malnutrition. So in those patients, maybe we do a sleeve. Along with the sleeve, we do some form of fundoplication like a two-piece. We don't do a 360-degree wrap, we do a two-piece fundoplication, or we do some other form of fundoplication. So there, those subset of patients definitely help. It has been shown that we can still do it.
Sir, we came to know when I was introducing you that you are doing all kinds of surgeries, sir. In minimal access, you are even doing thoracic surgeries.
Correct, sir.
And you showed a case of thymoma.
That was a thymoma surgery.
Which you have done.
Video didn't run well.
I just wanted to know, when you do a thymoma, you do it on your own or you involve a thoracic surgeon?
So we do on our own completely. Again, like I said, this was again on an institute thing which we used to do a lot of thymomas. So if I could show you the complete video some other time, I would have shown you every structure dissected, every nerve identified, labeled, everything. Because
I was very afraid when I saw the bleeding heart.
It is very wonderful to see that. It really gives me great thrill to dissect.
Doctor, I was really paranoid when I saw that bleeding heart. I thought you would probably have removed a bypass surgery.
Not required.
As a standby. Not even as a standby.
Nobody did it.
Wow.
I have a paper published, not a paper. I have a chapter in one of the minimal access textbooks of surgery. Last year it was published at Singapore. Advanced minimal access surgery, in which I have written a chapter on thoracoscopic myopathy.
Wow. We are so proud.
This was the invited paper, so I just wrote
We
that chapter.
are so proud of you. Doctor, Dr. Tulsi will ask you many questions and you have to be patient.
Sure, sir.
Not many questions, just a few basic questions. So, Dr. Shalini and Dr. Aloy Mukherjee. So those were wonderful talks. And Dr. Chauhan has promised me a CME on medical bariatric. On drugs which would reduce, another day over a single malt, you said? At my home?
Yes.
He said yes. Okay. Naveen says they will all be coming. Anyway, let me proceed. Dr. Lai, laparoscopic Nissan fundoplication is currently the gold standard for treating GERD, which is probably, resistant to responding to drugs or other non-invasive treatments, repeated aspiration pneumonias or asthma related to reflux. Parents, of course, and younger patients who don't want to take chronic medications. Is this the identification for?
Absolutely, sir. That is spot on there. Those are the kind of patients which would qualify.
So, do newer weight loss medications like the GLP-1 agonists, the GLP-1, GIP, and the triple agonists, right? So, does it mean the end of bariatric surgery? See, as newer weight loss medications can, cause a weight loss of more than 20%, which was never thought about, except for bariatric surgery. So, have you reduced the values?
So let me just answer that.
Yeah.
So first of all, obviously, everything has its own indications. So definitely, we use GLP-1 agonists, and they have definitely helped us. Two subset of patients I would just talk. Number one is patients who have maybe a class 1 obesity, and patients who have severe comorbidities who don't qualify, or people who are so super morbidly obese, like BMI over 60 plus, who would require some reduction. Now we have this 212 coming here very often. So in them we use this as a pre-surgical method to decrease some weight. 20% is what the textbooks say. Most of these GLP-1 agonists, the endoscopic balloon, the Lorion pill, all of these, in our experience, Deepa, I would say somewhere between 8 to 14%. Am I correct?
The GLP-1 RA they are endogenous supply. But when we are stopping these medication, there is a chance of decrease of weight gain, and in approximately 73 to 72% of the patients I have seen that. That's why it should be adjuvant with this bariatric surgery.
You're very right.
So maybe as an adjunct, or maybe using these subjects. So maybe you prime them that way, and maybe or people who are not compliant, who don't want to.
So, Doctor, let me discuss a real world scenario case with you. Lady, 60 years old, with a BMI of 40, and with type 2 diabetes. Poorly controlled.
16 years old.
60.
Oh, you are imagining 16?
16, so it's 60.
No, I'm not imagining.
Let me.
I just misheard.
Naveen, let me proceed. So, poorly controlled with an HbA1c of 10.1. We took her on semaglutide once a week for about a year.
Semaglutide once a week.
It's not available.
Injectable.
Not available.
Not available in
Not available. Who said it's available, sir?
Dubai se available.
This is a British woman. I'm just discussing a case.
Okay.
A real life scenario. Not related to our country.
No, I became real actually because it's not available.
It's available, not in India. Anyway, let me proceed. So, semaglutide 2.4 milligrams subcutaneous once a week was given to this British lady.
This one authentic.
Yes.
Absolutely. So, Wegovy, 2.4 milligrams subcutaneous once a week available. Her diabetes became amazingly better. Her HbA1c was 7%, down from 10.1%. You are a diabetologist, you would know. So, she achieved a weight loss of about 8 kg at about 6 months. So, she comes to Dr. Aloy and she says, I want a bariatric surgery for further weight loss. What should you do? Do you want her to switch, as Dr. Chauhan would say, to tirzepatide or Mounjaro?
Not available yet.
Sir, this is the British, it is available, British Mussoorie.
Yeah, in UK.
क्या चाहिए?
They will make a...
Or, what Dr. Chauhan say, tirzepatide, which is a triple agonist, or would you like to do a bariatric surgery? This patient wants a bariatric surgery for more weight loss. So would you recommend, or Dr. Chauhan recommend, Mounjaro or retitriptide in this patient, or would you go for a bariatric surgery? Mind you, let me complete. Mind you, this is a patient just 60 years old and just T2 diabetes, lost weight at 6 months, just about 8 kgs. She wants further reduction with a bariatric surgery.
What is the best thing?
She comes to you, so what, as Dr. Chauhan said, what is the way forward?
We have to evaluate the patient. We have to check how long the patient is suffering from the diabetes. If the diabetes patient is on more than 2 OHA and diabetes is more than 5 to 7 years, then the patient is not going to get much benefit from that. But obviously, patient is going to get benefit with the bariatric surgery. Just from the point of view of weight reduction, we can definitely suggest a lesser maladaptive procedure. But for the HbA1c point of view, we have to check the C-peptide level.
HbA1c is excellent now. At 7. She wants a further weight loss.
Yeah, we can hit the further weight loss.
Would you recommend the other agonists, not only the GLP-1 agonists, as Dr. Chauhan said, tirzepatide or Mounjaro or retitriptide? Or would you go for a bariatric surgery? She wants a bariatric surgery. This is a Pandora box. None of us are, very clear, extraordinarily clear to say what is the best option here.
Absolutely, sir. She's 60 years. She's got a BMI of 40. She's lost about 8 kilograms.
At 6 months.
At 6 months, HbA1c is remarkably resolved. And she's got refractory to, semaglutide. So, from her diabetic standpoint, she stands corrected. From her weight loss standpoint, we not only look at diabetes as a comorbidity for her obesity, we have to look at other parameters like arthritis. We have to look at other parameters like obstructive sleep apnea, cardiac functions.
She doesn't have.
Reflux. She has no comorbidities.
No, nothing apart from T2 diabetes. And no, this is morbid obesity. Anybody who has a BMI of more than 40
absolutely
is a morbid obesity.
Absolutely, class 3.
So Dr. Kalra, what would be the weight here? With a BMI of 40? Can you tell us that?
Must be 100
Must be
120 kgs, and she lost only 8 kgs in 6 months. I think this is an excellent candidate for a bariatric surgery.
तुलसी सर, मेरा मन ये कह रहा है बार बार कि अगर उसको दोबारा ब्याह कराना है तो पहले bariatric surgery करवा ले. Otherwise she can wait for other medicines. They will be very effective.
Are there any other questions? Okay. No. I think we had a wonderful session with Dr. Aloy and the wonderful team. Sir, we need another session. We need another session in March.
अभी तो दिल भरा नहीं।
अभी तो दिल भरा नहीं।
दिल अभी भरा नहीं, पेट भरा हुआ है।
सर मैं ये कह रहा था,
पेट भरेगा तो रिजेक्टिव हो जाए।
Before I give it to Dr. Kala sir to some of the medical management part and to Dr. Podar sir who is getting repeated calls because he has a gallbladder to operate which is not going to give to you because he is working with Dr. Arun Prasad. So, no problem. Sir, we know the affiliation, but we are not bound by Dr. S.K. Podar, we will give it to you. Sir, kindly summarize the medical management part. My honor, Dr. Kala.
Dear friends, so we have had very nice and very interactive sessions. So all the GERD patients we are treating and we have all the rights to treat, but whenever there are red flags, we have to involve a specialist like our friends, Dr. Shalini, Dr. Aloy Mukherjee. Wherever we find that the patient is having weight loss, above 50, anemia, not responding to the routine treatment, so they are our friends. We have to refer to them for the benefit of our own self and our patient. And for surgical management, I would say Dr. S.K. Podar has a right to give matters.
Would you like to talk about nutritional deficiency?
Next time.
Next time?
Only thing
there is a festival called Holi. There is a festival called March.
What time?
We will call Dr.